So good morning, everyone. Sorry, we are a few minutes late, but we should get started. And maybe we'll start with introductions around the table. This is Shuli Gerowich from HSCRC.
Allison Schuster, HSCRC. Andy Zumbrum, HSCRC.
Bob Murray, representing Care First.
Teresa Lee, MHCC.
Tracy Laval from the Maryland Hospital Association.
There we go. Tony Tucker, OPM.
Ed Baranik, Johns Hopkins Health System.
Patrick Rolano, University of Maryland System.
Ben Turner, Primary Care Coalition of Montgomery County.
Chad Perman, DHMH.
Noy Reed, HSCRC.
Denise Johnson, HSCRC.
Andy Udom, HSCRC.
Diane Feeney, HSCRC. Just real quick welcome to Noy, who's our new Chief of Quality Analysis.
Donna Kinzer, HSCRC. So we have, when I pick up the printouts this morning, I'm like, wow, that's the heavy set. Some of them are references for you to review, and we included the recommendations that we presented at the commission meeting. Okay. Oh, I'm sorry. All right. So we should get going with the agenda. We thought we start with the future strategy first, because I think it will inform us with the readmission discussion and the PAU discussion that we're going to have. So with that, I'm just going to go to the PowerPoint. So, you know, been discussing this on and off in our meetings in terms of what the future of our pay-for-performance programs look like, given that all-payer model is progressing into total cost and linkage with the non-hospital providers. We also heard comments in several meetings about the complexity of our programs, and are there ways in which we can simplify and align with the way they are implemented on the ground at the hospitals or at other providers. So as you know, our programs QBR, MHAC, readmission, shared savings, and now we're measuring PAUs. There are some commonalities. The way we score usually is the same, but the way we adjust the payments are different. And right now they are living kind of independent from each other. So there is no additional consideration if the hospital is doing better in all of them, right? If they are kind of an independent additive impact. The new model is, you know, increasingly focusing on care coordination and addressing high-need patients and chronic patients. And when we look at our measures, you know, we need to think about how we are going to align the measure sets into the new focus of the all-payer model. And also on the care coordination side, when we discuss the additional infrastructure resources provided to the hospitals under the GBRs, the recommendation from the commissioners is how do we think about measuring the outcomes for these new investments, either in terms of the process, right, how are they implemented, or in terms of outcomes, what do we need to do to kind of now look at the impact of those additional resources in the state. On the national side, obviously the population health and patient-centeredness and patient-reported outcomes is dominating the quality discussion, quality measurement discussion. So there are things we could probably borrow from those discussions as well. And in general, as you know, CMS is moving towards creating more of a composite scores, and we need to think about star rating and how applicable it is. Is there things we could do there? And finally, a couple years ago, we made the commitment to get all the outpatient measures reported to the CMS, and the goal was once they're in the pipeline, we were going to come back and try to think about ways of measuring and incorporating them into pay-for-performance programs. And I think now we have enough historical data on the outpatient measures, mainly emergency waiting times and also the imaging measures. So this could be the time to pause and think about these all together and see what we could do moving forward. And I think, Donna, if you want to add some comments to it.
Yeah, I think one of the, in terms of the alignment strategies, one of the alignment strategies is really to focus on developing measures that can be used across all provider systems. So, for example, things like PQIs, the prevention quality indicators that we've already started to use, are used with the primary care doctors in most of their value-based payment models. So if we have, and even the specialty models will start incorporating things like the MIPS that are coming out. We'll start incorporating things like readmissions and population health measures. But if we have the entire system focused on the same measures, then we're more likely to actually accomplish the goals because everybody's working toward the same measures in their value-based payment program. So we don't necessarily have to have everybody under one integrated system if their value-based payment models are actually driving them to solve the same problem. So, you know, the avoidable admissions, the smoking cessation, the hypertension, and so it becomes about how do we hold the system, the hospital, the doctors, the nursing homes, how do we hold everybody accountable for the same measures to the extent that we can as we drive forward. So when we're thinking about that, we have to think about how we're going to need to drive the whole system, and that we want hospitals we want to make sure that hospitals are also focused on the measures that are outside of the walls of the hospital as we take on the responsibility, more responsibility for the total system. So just wanted to make that point.
And Diane prepared some of the reference materials we included if you want. I think this kind of ties up to that list that she's been working on.
Sure. I guess, should we flip to the next one?
Is it there?
The measures are not there, but there's the questions. Okay. Maybe we should go to those. So there are 3 different files that were labeled background in your packet. One is a set of NCQA updates for fiscal 16. One is the CMS, what they're calling core measures, and they cross facility and provider types as well as topic types and domain types. And then there's a third overlapping list of some measures that we at Aegis CRC put together based on some early discussions. So before we go into those, let me welcome Barbara Epke from LifeBridge, who just came, and then Stephanie Clapper from Healthcare for All, who's also on the work group, is on the webinar. Kim, let me know. So, welcome. So I wanted to just review some of the potentially key questions that we want to ask, and Donna sort of already said them with no slide to prompt. But let's just go through them sort of with them written down in front of us, and then think about if there are other questions we want to answer. And then what I think we'll do is probably walk through the CMS core measures with references to the other material, but not in great detail, just kind of to look at the sets, basically, and point out a few key measures that we, at least at HSCRC, have been more potentially zoning in on. So first question is, how do we want to look in 5 years in terms of our performance measurement system? So within that context, what are the necessary components of a comprehensive measurement strategy that has broad population impact and achieves the triple aim of improved care, cost, and patient experience? What are the potential opportunities for expanding PAUs, since that really gets at the cost and care improvement side of the triple aim? What clinical topics have potential for broader upstream impact, like the things that Donna's already mentioned, obesity, hypertension management, smoking cessation, and mental health and depression screening, we think potentially has a great opportunity as well for broad impact. And then what domains need to be captured? The ones that we're working with: mortality, complications, readmission, safety. Should we look at measures in context of clinical topic areas? And should we look at a composite, for instance, of a clinical topic area that crosses domains and crosses settings of care, or should we continue along the lines now where we have different domains of measures on various topics that roll up into a score? And then, so should we keep readmission separate, for instance, for the same patient type, or should we combine readmissions and complications in these other domains for the same patient type? And then should we align our measurement strategy with the direction that Medicare is going? And we have always had sort of a principle of moving forward that we do want to be in sync with what is happening nationally, and to align or harmonize our measures and leverage the opportunities for data collection and measurement that's already being done, as Don's already mentioned. And then who needs to be critically important at the table? Are we missing key participants that need to have a voice at the table as we discuss these issues? And to that end, just as a quick aside, we are looking at a consumer engagement sort of committee that's we're still kind of trying to figure out. And so we believe that the consumer voice needs to be continually brought into the conversation and be very important, since after all, that is the reason we are doing all of this. So with that, what I'd like to do is maybe call our attention to the biggest background document, which is the consensus core set that CMS has put together. And I did number them, even though the sets are separate, but they're numbered consecutively so that we can refer to pages as we sort of run through these. The first set is the ACO and primary care medical home set of measures, and these are obviously segmented by patient type. So we have first cardiovascular care, and there, one of the things we thought might be quite important to measure and have a very big upstream impact is controlling hypertension. And so you get at that, not quite the mass at the bottom of the pyramid, but the one layer up at the pyramid where there's potential for chronic illness, but also for great improvement with early screening and treatment. And then as we move forward through the document, page 3 starts the diabetes measures. We know that diabetes is, epidemic proportions, and should we pick one or all or some of these measures? Care coordination, and the one measure here is is under patient safety subdomain, and medication reconciliation. And then there are a number of prevention and wellness screening measures for tobacco and cancer issues. Certainly colorectal cancer screening sticks out in my mind as something that maybe have that great potential. And then as we move to page 8, there's a utilization and cost, and the measures that Shule mentioned around imaging and outpatient is use of imaging for low back pain, maybe something. And then there's patient experience, as we know and love that measure here. But of course, it's not just designed for hospital; it's for health plan and for the provider setting. And then I think in one of these documents, there's a segment of CAPS that also addresses orthopedic surgery patients, so that we could look at it at that more granular level if we want to look at condition-specific measurement. And then for behavioral health, something that's quite intriguing to me is that it would be, it could have potentially very broad impact if there could be better screening and early treatment of depression. And a broadly used tool is the PHQ-9, and there is certainly I think an electronic method to collect that data, and I don't know how ubiquitous it is. I think Noe has worked, she could help us with some of this as she's worked in provider office settings before coming here with the PHQ survey itself and data collection. And then as we move forward, there's pulmonary measures. So those are sort of the condition specific. And then in the next section, CMS has also segmented their measures just for, I think, viewing and separation purposes into, again, clinical topics, congestive heart failure, hypertension, ischemic heart disease. These are all cardiovascular measures. And then as you move to page 21, I'm sorry, let's go to 24. We do see the gastroenterology measures, and these are, again, a repeat of colonoscopy screening. And then as we go to page 28, medical oncology measure set, there is a big question whether we really should be focusing on oncology patients, and how do we measure the cost, the total cost of care in a bundle, and how do we measure whether the care is effective and the quality is good. So these cancer measures have the potential to provide that measurement. And then there is hospice and end-of-life set of measures within there. And then page 31 has OBGYN measures as well. And we see this age-old measure of cesarean section rates. And that is a measure that has been around for decades. And we know that there should be some good practice around that, but we haven't adopted that into any payment mechanism to date. So I would like to talk about that measure in particular. And let's see, can we get to the end of these? And then there's these orthopedic measures at the very end on page 34. So, so if you look at the other two sets, the NCQA measures are, NCQA are pretty much subsumed in the score set that CMS put together. And then there's a couple on the yet another version, the HSCRC version of measures that I just want to call our attention to. And then I'll stop talking and ask if we could have a discussion. That there's a 30-day outpatient measures following colonoscopy and outpatient surgery that for returning to the emergency room. And these measures could be potential opportunities. We know that they're at the bottom of page 1 of the HSCRC document. And these are measures that are being developed by, I'm sorry, there are 7-day follow-up measures in the ER post outpatient surgery and colonoscopy. And there are Yale researchers working with CMS to refine these measure specifications, and specifically, could we consider those under the potentially avoidable utilization area conceptually, understanding that we may sort of redesign how we think about packaging and measuring these for payments. So I want to stop talking about the measures and let other people talk.
Yeah, let me just kind of, the rainbow slide I prepared. I noticed I've been drawing a lot of rainbows with my 5-year-old daughter, so I think that's impacting my thinking. But if we were to kind of think about reorganization of our programs and look at it from a different perspective, one way of thinking about it, and that came also from some of the stakeholders, is could we break the measurement into specific service lines and try to make it more patient-centric? So I just draw a straw man type, like if we break the hospital services by service lines and we need to discuss what detail we need to go down, but medicine, surgery, obstetrics, psychiatry, oncology, etc., and then align all the measures or the domains like in our QBR program. And then the question is, if we do it this way, do we pay attention, how do we combine them and get an overall score across all these domains? Obviously, some of the measures like the PQIs and other population health measures may not neatly fit, into this nice cells and the grid. So we need to think about how we could get that on and create like an overall type of performance. So the discussions, I think this is a big change in my view in terms of the way we've been doing performance measurement, right? We've been looking at a hospital PPC score. We've been looking at hospital readmission rate, whereas CMS has been focused on their top 3 AMIs, heart failure, and pneumonia mostly. Now they're adding other patient classifications. So to me, it's a big change in the way that we would think, and I think it requires a lot of thinking and kind of reflection on what's worked, what didn't work, and how, if you're moving, how we can get it all together, and what would be the timelines for such a change if you all think that it is worth pursuing. All right, so that's kind of all our leads for you to start talking.
So I'll just start. This is Tracy Laval. I think it does make sense to look at alignment of measurement across provider types and have everyone rowing in the same direction. That's a good principle, and it's a good something to look forward to and something to work towards. We said this is like a 5-year, where do we want to be in 5 years? So I don't know exactly where we'll be in 5 years, but that's something that we can look forward to. I think one of the challenges when we look at that measurement alignment, to me, we're looking at a lot of population health measures, which is something that we all want to affect. And that's a good thing to look at. Our challenge with that, and I don't think we've solved that yet, we haven't worked a lot on it, but is what's the population? If we're measuring that for a hospital, what is that population? So it's clear if it's an ACO or if it's a primary care practice, you know who that population is. I think that's one of the things that we'll have to address if we want to look more at population health measures for a hospital. You look like
I don't want to stop you from commenting, but we actually do have a sub-work group coming out of our new model development to focus on geographic model. And so to define geographic service area and a population related to a hospital, for example, or a regional partnership. So it is a discussion that has to happen. So I just wanted to acknowledge that it's going to get on the drawing board here pretty quickly.
Can I just mind if I ask a question just associated, because I'm trying to, again, totally agree with all of these measures in the sense of they're good for our patients. I'm trying to understand how, is there a vision yet, or maybe not, of how do we start? I think it's along the line of what Tracy was saying. When we're looking at post-hospitalization, we know where we can capture that patient initially, and that's the index admission, and then we can deal with the transitions of care for 30 days after. I'm not exactly sure. I don't yet have the vision of how do we capture this population before they get to us.
So we're working on getting the data for you, so that you would have for at least starting with the Medicare patients, so that we would have Medicare data for service areas, and we would be able to focus on patients that could benefit from community-based interventions, and that would be something, as you're trying to make sure that they don't land in the hospital, then you want to make sure that they're getting community-based interventions, and so you want to be part of a collaborative with doctors and
other providers who are going to be focusing on how to control blood pressure to make sure the person doesn't end up in your hospital with a stroke. So I think that's really the thought. That's a thought process of the ACO, but that's also a population-based thought process that we're going to be discussing based on geography. And so let's take university, for example. So you have a great big global budget that has people from all over the state, but your population-based approach would be the patients that are in your immediate service area, not people from all over the state. So as you're focusing on your population-based strategy, it might be different than your so it would take on more of a local primary service area type of thought process.
So is this care management opportunity? I'm still trying to figure out.
Yeah.
Well, I know what we would.
Definitely a care management opportunity.
So the anticipation would we would set up proactive care management
for the high needs patients, that you would have proactive care management, and then for those with with significant chronic care conditions, that you would set up proactive programs with primary care doctors and other providers in the community. Get away from that microphone. Who would be taking care of those patients with a lot of chronic care needs, because we call them rising risk. So they're going to end up being a high needs patient if you don't address their chronic care conditions. So that's
but not being a finance person, so but those global budgets are based on populations that are hospital-based at this point. And all payer, right.
an all-payer, right.
So it doesn't cover us managing patients across our communities, per se.
We actually did put money in your rates to
build infrastructure.
To manage patients across the community. Yes, we did. So we did put money in your rates for that already. But if you think about how are you going to manage your hospital cost, no, I'm talking about the hospital cost. How are you going to manage your hospital cost under a global budget? Is by reducing avoidable utilization that can be addressed through reducing readmissions or reducing events that start in the community that end up in the hospital. So there are some hospitals who've already implemented some really great long-term care strategies with the nursing homes, where they're putting more clinical interventions in the nursing homes. We have some hospitals who are telling us they're getting their admissions down by 70%. And I'm looking at Barbara as one of the institutions who's implemented some great nursing home strategies already. And so that's reducing the hospital's pressure in their global budget, and they're not having trouble affording cancer drugs at LifeBridge because they've gotten avoidable utilization out of their hospital. So that's an example of an investment in outside of the hospital that's paying off inside of the hospital.
So can I maybe break in here?
Yeah, I'm sorry, I didn't mean to go off sideways there on you, Tracy.
No, it's okay. So I think we're all clear about the global budgets and managing care and moving beyond the hospital borders. I think to me, when maybe the direction that's in Pat's mind is, yes, we're moving outside the hospital to reduce avoidable utilization and touch managed care better so people aren't admitted, and there's all kinds of different strategies happening there. I think when we start to look at the measures that are typically ACO measures or PCMH measures, that gets to a level of detail and a level of patient management that's a primary care management. And I would say even the hospitals, say the TPR hospitals that have been on global budgets for a longer time, they, I'm going to hazard a guess, are not tracking those PCMH and ACO kinds of measures for their own accountability. They may want to know what's happening there. They may be keeping track of those, but you know, there's the potential, I think, for us to look at some of these measures and say, we're going to hold a hospital accountable for any one of those ACO measures. And I think that's probably a step further than where we are right now. And until you know, until there's until a hospital is part of an ACO or some other kind of arrangement, then I think I think that's where the discomfort comes in.
I mean, we provided those ACO measures and everything as a reference. I don't think we are not seeing that, oh, we are going to take the diabetes H1 control measure and apply it to the hospital. So I think what we are trying to do is look at all the ACO measures, and for population management, this is what they are looking at. And then how do we translate those into a hospital level and what it means to be a good performer under global budget. And I do think there's a lot of discussion happening on the efficiency side, right? Because on the efficiency side, it's clear that average charge per case is not an applicable measure under global budget. But from your perspective, what does that mean from the population health measure, from the hospital quality measure? So, and I think one idea is, look at all these measures, look at what the ACOs are doing, and federal government and everybody is trying to align the measures across programs. And then how do we translate that into a hospital level measure? And I agree, we need to figure out the population, but some of them, the readmissions, we didn't define population. It is a hospital level.
And I do believe, and we're already in the midst, and many hospitals are, of partnering with our physicians to look at variations in practice and care. And these metrics are great for us to initiate that conversation. It just goes back to how much we can influence, and then the concern of literally taking risk, payment risk, when in fact that's an evolving process. So I'm just trying to understand and visualize how it would work. I'm not disagreeing.
Barbara?
First of all, it would be hard to argue with the importance of population health, and that should be our measurement over 5 years. And I know that that's going to take a lot of testing and modeling to figure out how to measure. I want to go in a slightly different direction if we could. Can I go back to your rainbow chart?
Sure.
I actually like the way this is broken down, but I have a question that's bothering me a bit. When I look at the green stripe, the overall score, I want us to just keep in mind as we go through the modeling in 5 years that sometimes when a hospital tries to do what Pat and Tracy are talking about, which is to decide what patients and what population to focus on, sometimes there's a greater expenditure, say in the cost column, let's say even for a prosthetic in surgery or whatever it might be, to diminish risk, to keep the overall long-term cost down. So I would just caution us. I know we always look for, CMS does too, some sort of composite score. And that is very hard to arrive at if you want to undergo change. So I would just say, as we start out on this 5-year journey, could we please make sure that we are taking into consideration the huge disparity between the high-risk patients and their cost and the lower or moderate risk patients, and what the cost investment might be, whether it's a high-risk mom, whether it's a high-risk diabetic, whatever. It may cause one of these columns to be somewhat out of proportion, but in the long run it may benefit us. So it's just a note of caution if there is an overall score that we're to be judged by.
I think that's a good point, and I'm glad you started in there on these ideas. I think a lot of us have talked about breaking out the different policies and looking by service lines, and that's something that we like. I think there is value in continuing to be able to clearly see the different I don't know if I want to call them domains, but different metrics, the PPCs, the readmissions, the mortality, to see those separately, because each one of them has their strengths and their weaknesses, and we have to risk adjust each one in a different way. And so the more that, if we roll them all into one bucket, there's the possibility of losing some of that granularity and that specificity, and I think we don't want to paper over any of that, but make sure that we still continue to have a solid risk adjustment on each one of those. But I do think it is helpful to start to look along service lines.
I do want to just make a comment about before. I think the more we think about some of these measures that are more outcome-oriented versus process measures, that we are going to have to start thinking seriously, maybe not today, but down the line, about some of the measures, particularly around chronic disease, that we are going to have to be serious about controlling things like hypertension, diabetes, and that it's going to have to be a cross-setting. And we can't just say that's the responsibility of another setting. And eventually, that's going to have to drive care. It's going to have to drive partnerships, so that it will be responsibility of hospitals. It will be the responsibility of primary care, long-term care community. So maybe it's not an appropriate, measure to have, doing screenings in the hospital. But if we're all responsible for controlling hypertension, we are going to have to change our practice. So I think we have to start thinking seriously about including these type of measures.
Speaking for the hospital, I totally agree, and that's why I'm trying to visualize what we can drive, not what are we accountable for, but what can we drive, and then looking at metrics to ensure we are fulfilling that responsibility. So I agree.
Yeah, and Pat, I think, we didn't bring the other work, but the alignment work has been actively thinking about how we would get physicians and post-acute providers aligned with these models, and from the payment incentive side, what we can do to get them in the same incentive environment. So I think that's kind of one, and the other about this geography and trying to localize the population health measure where hospital can really have an impact is the other kind of way of thinking of incorporating some of these population health measures into the performance domain.
To me, that is exactly the linchpin in all of this. I agree completely with you about the chronic disease and measuring that and having providers aligned in responsibility for that. And I think when we can get to the point where we can make some geographic assignments of responsibility, then we can measure the prevalence of those conditions in that population and measure change over time. Because we know that there are, I think HSCRC facilitated us getting that data to see those differences in prevalence of the chronic conditions geographically.
And this is Pat again. I also wanted to say that I believe the patient-centered strategy is the way we have to go. And even when we're talking about these chronic diseases, we need to start thinking about, not just readmissions, and yes, we have a COPD problem, but what is our care of COPD across the continuum? And I know that's what you're getting to, and we agree with that wholeheartedly. The only recommendation I would make, kind of consistent with, I think, what Barbara was saying, is some of those may need to be stratified because you will have different levels of surgery, as an example, more complex versus less complex.
Yeah, I mean, this is kind of my, yeah. I'm not proposing this as the recommendation. Any other comments on this topic? So in terms of moving forward, in timing, we've been thinking about this, and we were initially planning to do some revisions by the next cycle for calendar year 17. But in order for us to do it, we need to kind of have this 5-year vision where we are moving and what we want to accomplish going forward in increments. So, we are going to group a little bit with the staff to think what the process should be for us to work on that, but also some key questions about the direction, and we need to get some kind of an alignment on, is this the direction that we all want to move, and then what the pace of that movement is.
I think the state is coming out with a new population health plan pretty soon, and so we want to get a look at that and see what they have targeted to improve and how that should fit into our thinking, and make sure that we're thinking about that at the same time.
Just one thought, a principle that we have relied on in the past has been, as we look at new measures, we agree that we'll report on them for 2 years before we put them into payment policy. So especially as we look at developing geographic regions, I would encourage us to remember that approach and start reporting on metrics and having, so that providers can look at them and we can make modifications as needed, but to report on them for 2 years.
No, one of the challenge, I think, though, is you mentioned the care coordination activities and our need for high-risk, high-need patients. So I do think that there is an immediate need, in my mind, to think about how do we measure that progress and what kind of additional incentives we need to make, because until now we kind of treat it as an infrastructure investment, and we put it in the rates, and we've been collecting, and Andy works on our global budget reporting and all the applications for the grant. So until now, it was, we provided the money for the infrastructure investment, and we collected some information, but it's not a rigorous information to be able to look at the progress and the outcomes. So I think, given how much money invested in our 5-year timelines, I do think that we need to move forward thinking about what measures we can have immediately and start looking at the impact of those investments.
Yeah, and the Commission, in adopting a recommendation to put funding and rates, said there had to be an ROI, and that we had to figure out how to measure the implementation. So so that was a kind of a quid pro quo in terms of you're not going to get the money unless there's going to be some outcomes measurement put in place, and that was I'll call that the payer detente, was a discussion of expecting to have a process in place to measure implementation.
I remember that, and I hear what you're saying about money and rates and what that's for and return on investment.
And we do have things too. I mean, we have a new model, and there are things that are already happening in the new model.
I'm sorry. What new model are you referring to?
January 1, 2014.
Oh, okay.
We have a
like
new
2
model,
years old, so.
and so we may not have the luxury always of waiting 2 years to. We have a new model. We have to, and we went from a per case model to a per capita model. We don't necessarily always have the luxury to wait 2 years to put in new measures if we're having problems. So, for example, we're having some growth outside of the hospital. So what do we need to do to tweak things? And so we may not have a 2-year window to work with, because we have a new model and we have to do some tweaking faster to make sure that we make adjustments. So ideally, we like 2 years, but it may not always be possible when we're in a brand new situation.
I hear what you're saying about that. A couple points, though. There's two things. There's one, if we're measuring, we want to be sure that we're measuring what we think we're measuring. So if we just roll out a measure and start adjusting rates for that, but we don't really have confidence that the measure is, I'll say, fair, then I think that's a problem. And that's really the reason why we have that 2-year period of monitoring metrics. So the second thing is about population health changes is the timing of measurement. So we all understood that there was a need for a return on investment, but the question is, how long would you before you would expect that return on investment? I think the PCMH programs, the ACOs, they would all expect at least 3 years before starting to see a return. Our TPR hospitals would also say that it really took them that amount of time before they started to see changes in those population health metrics. So we've seen complications come down quickly. That's within the hospital. We've seen readmissions taking the first couple years were slower. They're going faster now. That's a little more expansive. The prevention quality indicators, those are more broad. They're further outside the hospital. It takes longer to affect those. So we don't have any objection to measuring population health measures, but we do want to make sure that what we're measuring, what we think we're measuring, and that we're also making sure that we measure in a time frame that's reasonable to expect change.
Can I just interject quickly? Many of the measures have been in use by the ACOs and PCMH programs, so the idea is how to count them in with the facility measures. And I don't know that a 2-year period is necessary if these measures have been in broad use, have been validated, have been approved through a national consensus process. So I think there needs to be some flexibility about that.
Yeah, you're right, and we do appreciate the using measures that have been vetted. In these measures, it more comes down to that population assignment. Is that population assignment appropriate? And I think that's where we'd want to see, we could use a measure that's been in use by the ACOs, and we know it's a solid measure, but if it's applied to a population that's not appropriate, then that's where the problem comes in.
Yeah, and I think when you're talking about the population health measures, it does take a little longer, especially on some of those measures, and it will take a while to accumulate the data and actually be able to measure some of the things. We are measuring some of them already, but not necessarily in a geographic level. But and also, with some of the measures, you start out with a small amount of money. You don't start out with the sky-high amounts of money, and you decide how to change that over time. But you have to keep the performance, the amount of money that's put on the performance lower to start with as you're implementing. And it gives people time to put their foot on the gas pedal based on your intention. And I do agree with Chad in terms of outcomes, move towards outcomes. But since we are starting this a new process for care coordination, are there process measures that we can use? We thought about high need or rising need patients. What is the, okay, we'll figure out the assignment attribution thing, but what is the percentage of high need patients that your hospital see who are receiving care coordination? It is a process measure, and if you do an improvement, not level, what was in your base, how much you're getting, that could be a simple way. We have another measure on the monitoring list of the follow-up after a discharge within 7 or 14 days follow-ups, and they are validated measures. I don't think hospitals are seeing that, but we could if you pick couple
measures that are relevant now, both process and ideal outcome. But okay, outcome is going to take a while. But I do think that now we are a little bit blind in terms of the progress on an implementation, and also given the need for the speedy scale up. We need that kind of development, I think. And I don't think the timelines are enough for us to go through a whole formal process and get those all.
Julie, I think that was consistent with my
Right.
comment of what should we be doing to drive.
Right. And I think that will help in implementation if you have a better sense of where you are vis-a-vis your peers and what is the attainable levels. All right. And so, as I said, we'll follow up and think about the timelines. Maybe by next meeting, we can think about how we want to structure the process between now and next December if we are changing certain things and developing certain measures for that purpose. So with that, I'm going to move to a potentially avoidable utilization update. And we shared this with Commission inside of the readmission recommendation a little bit, but obviously we want to have a more extensive discussions with you. So I pulled some of the earlier definitions, and hopefully it will give us some thinking for the general definition. So this was what we decided 2 years ago, I think, that we were defining potentially avoidable utilization as unplanned and can be prevented through improved care, effective primary care, and improved population health. So that was kind of the broader definition that we adopted with you all. And then from there, we've been looking at the PQI's readmissions as an operational definitions of the PAU. So if you think about the unplanned admissions as broader concept, what I kind of started looking at is this medical admissions from emergency, right? That kind of is, I think, the most broader thing that you can think about as an unplanned admission. So in general, in the state, so this is fiscal year 2015, 55% of all inpatient, and this includes observation 24-hour and more, 55% of them are medical admissions from ED. And then when you look at the surgical from ED, it's only 7% of total utilization. And the other admission sources, you see the 24% from other non-ED, and 15% of surgical is also probably I would say the planned admissions are the 15% most likely. And here from our data, if the patient is coming from nursing home, they are coming in through ED, so they are all kind of lumped up into the ED as a source of admission. From this bigger perspective, this was our operational definitions for 2016. As you know, we have readmissions and revisits. So last year we combined the observation cases into the algorithm. So this is different than the readmission risk adjustment where it's only inpatient. So this is a broader, including the observation cases in. But the same algorithm, 30-day, all DRG plans excluded. And we include PQIs. We already discussed the ARC measures. And we were estimating cost of hospital-acquired conditions, PPCs, and then looking at the percent revenue for the hospital. So the adjustments that we've been using on PAU is in the demographic adjustment, and it is a complicated topic, but I tried to just say we estimate the expected volume growth based on population growth and aging, and then we reduced that expected based on the PAU percentages. So that was the efficiency adjustment that we had on the global budget. So it varies by the hospital. If you have a lower PAU, then your expected volume growth is a little higher than another hospital if you had the same population growth and aging. I can repeat it again if you like. So with that, in the 2016, the average reduction was at 0.39, and then the maximum reduction based on the PAU percent was 1.1%. And in general total, the overall reduction at the state level was $26.9 million. So, thinking about the PAU in a broader context, I think we are treating PAU as an opportunity, not an assessment of the hospital performance, right? It is a % of revenue, and we acknowledge that the sources of PAUs are also related to non-hospital factors, community factors, and other things. So this is our link, very close link with the GBR. If we didn't have a GBR, global budget, I don't think we would have a PAU type of measure, right? This is our new concept. And with that, we are thinking about broadening this and really looking at maybe the ideally we want to do nursing home admissions, and that was our list from the last year. The data challenges are quite high there because we've been working, and Kristen is on the audience, and I know she's been working really hard to get that admission source cleaned up, but because of the ED as a gateway, it's been very challenging to get the nursing home admission source reliably measured in our data set. Teresha and I've been working on the minimum data set on the nursing home side. So that's a clinical data set for all nursing home residents. And we are working on trying to link that data set with our hospital data set, and that, if it works, should reliably tell us who are the nursing home residents coming to the hospitals, and also who is actually going to the nursing home as well. And with that, we've been looking at the sepsis admissions, and as you know, this is the highest, the number of admissions in the state, and also the evidence is suggesting that with the community interventions, 70% of these sepsis admissions could be preventable. The majority of them are coming from nursing homes, from the literature. So in lieu of trying to do a nursing home, we've been looking at the sepsis admissions. And I know you're going to say the coding issues around it. So this is the way we measured so far is taking the primary diagnoses and including the septicemia, and that includes only this 038 code in the primary. And when we look at the data, there is also a coding issue with the UTIs. We see the PQIs declining on the UTI, and then sepsis is increasing. So we think that if you measure sepsis overall, we also, actually we are going to improve the coding issue around sepsis and UTIs by combining them all together. So when we look at the data, what does it show to us is, so this is the hierarchy, so readmission first, and I separated it from ED and other source in general. So if you look at the grand total first, so in the state for fiscal year 2015, we had 86,000 admissions for readmissions, and then the PQI number is 64,000, the total grand total. And then after we take out readmissions and PQIs, we have 23,000 sepsis cases in the state. With that, the sepsis will be 13% of the overall PQIs if you add the sepsis into it. And overall, when you look at the admission source versus medical, 90% of the PAUs are from ED. And when you break it down, 93% of sepsis cases are from ED, 95% of PQIs from ED, and readmission is at 87%. And majority of these are medical cases. So what you have is the PAU, 92% of them are medical cases, and sepsis is 88%. So there are some surgical APRs in the sepsis. When I looked at it, it's the ECMO cases and operations with HIV. Those are the two surgical ones there. And then PQIs, 94% is medical cases, and on the readmission side is also 91% of those cases are medical cases. I'm not going to go through, but this is kind of combining medical versus surgical, and the percents is the overall, the 100%. So you could take a look at it, and if you want to look at more detail on those PAU versus non-PAU. So Tracy mentioned our progress on the readmission. So this is on an all-payer basis, looking at from the total charge perspective. So what you have is for readmissions, we have 1.2 billion total charge for readmissions, 651 million for PQI, and 500 million. So, you know, sepsis costs as much as the PQI, even though the case numbers are smaller. And what you have here is that we are concerned, and is the ECMAT change from calendar year 13 to 15. So, yes, global budget is giving us incentive to reduce PAU, but we purposefully put additional incentives on readmissions, and we are paying attention to readmissions. So we have 6% decline on the readmission cases. PQI takes longer, but yet, you know, it is around 0.8% decline, and the sepsis cases have increased by 14%. So given those trends, we thought that we could align the PAU measurement and take out the MHAC from the PAU measure and then instead put the sepsis into it. So it will align it with the utilization measure, so you would count the discharges rather than adding the MHAC cost on top of it. So it is kind of a utilization measure in a sense. And given our progress on MHACs, we want to reduce the impact of the MHACs in the payment adjustment, so that will align in that respect. And as we are moving towards more broader sense of PAU measure, you know, we think that it might be appropriate now to add the sepsis measures into the PAUs. And then you see the Medicare percents on the side. Since we, you know, we have an all-payer test, but the Medicare savings, we really have to have improvement on the utilization. PAU is a very good measure of focusing and making sure that we meet the Medicare test. So we have to reduce the PAU to meet the Medicare test. And in there, what you have is 55% of the PAUs are for the Medicare population. Then the, yeah, go. Oh, sure, go ahead, Pat. No, go ahead. I'd rather ask you questions in the middle.
First of all, again, I do understand the need to look at PAU, and that is our opportunity. What I ask is there consideration, the concern with the current PAU is the difference of looking at PAUs versus some of the other opportunities that are kind of risk-adjusted. PAU isn't. So that's one concern I have of how can we manage that to understand that, again, the opportunity at one hospital may be different in the sense of the opportunity at another. That said, I also, as a quality and clinical person, have a concern about sepsis. Not that I don't believe sepsis is a huge clinical need, I do. But looking at it as a PAU concerns me a great deal in the sense of knowing where that that condition is deriving from. Different than PQIs that are chronic diseases, sepsis is an acute body response. It's not actually even a core clinical problem. It's a body response to an infection. And I wonder, and I ask, if we could better understand truly the source of those patients. Are the majority of them coming from subacutes? Because that's not what we feel, and I know we need to look at data to understand. But there's a lot of these patients coming from the community, and that they've not sought medical care prior to coming through our door. And that's what concerns me in the sense of looking at it as a PAU. My other question, is the 14.2 just total admission increases, not readmission increases?
Or which 14?
It's ECMAT.
So that's the non-readmission, non-PQI sepsis increases.
Okay. So my question is this truly an increase, or is that shift from what we were used to have as hospital acquired that we now are identifying on arrival versus 3 days later because of our change in early identification and treatment, my question is it really a shift in the patient population we're seeing or earlier recognition of those patients coming in? And when we look at the MHAC reduction, they somewhat correlate.
Could you repeat the question? Could you repeat that question again?
Sure.
So I can understand the question.
Increase that you're seeing in sepsis admissions, not readmission, is, I believe, potentially contributed to the fact that we have put processes in place at the hospital for earlier identification. So we're paying attention in our EDs now of where we may have admitted a patient for another diagnosis and recognize sepsis later. We're recognizing it much earlier. So I don't know if this has an alignment with that change in process or change in practice.
Can I expand on that just a bit? Because my comments harmonize with Pat's, and this is around the definition of sepsis, and particularly of that first, kind of that first tier that's the inflammatory response. And the sepsis collaboratives, particularly the ones that the Maryland Patient Safety Center is running, and there are similar ones nationally, the emphasis there is to be able to, as Pat said, identify when a person is starting into sepsis in the emergency department, and within 3 hours get them started on fluids and antibiotics. And so what those safety collaboratives have been measuring is not so much the number of sepsis cases, but the number of people who actually die from the later stages of sepsis. And so the sepsis collaborative folks would see that an increase in the number of cases with a diagnosis of that first, I'll call it the first stage of sepsis, that's a positive thing, because that is identifying and catching people who may have later progressed onto a full-blown organ dysfunction.
Right, so this is including both of them. Just to be clear, this is including both of them. And even though there might be changes in the coding practices, at the end of the day, if you think about the PAU concept, what the PAU is trying to address is you stop them from becoming a case in the first place. So it is not PA present on admission related, right? So I think we are just concerned that we need to pay attention to these cases. Mortality is addressed in the mortality measure, and we've seen a lot of improvement on the mortality, right, or our inpatient measure. But if you think about the PAU in general, so if we have PQIs and readmissions, we think sepsis is the next candidate to broaden the PAU composition.
In terms of the coding issues, I mean, if you actually, do we have the PAU chart in here? The graphic? Oh yeah. So, I mean, if you start looking in through the variation of what's being coded as sepsis across the hospitals, it's pretty significant. And so, and one of the areas that we've looked at are UTIs. And I'll be honest with you, I'm now afraid by looking at this coding that I'm going to be admitted into an ICU unit if I walk into the ER with a UTI, because all of a sudden all of these UTIs and things that were recorded as UTIs in some of the hospitals, they've been recoded over to sepsis. I mean, that's what's showing up in the data, is that they've moved from urosepsis over to sepsis, or they've been moved out of you can see the PQIs go down by 46% and the sepsis go up by 46%. I mean, you can see the coding shift in the hospitals going on between the PQIs and the sepsis. And so and you know, maybe the mortality is down, and because we're putting patients that aren't really that sick into the coding. I mean, I don't know the answer to that question. I mean, hopefully the mortality really is down, because I've actually seen
a stark reduction in the mortality when people would have put in the sepsis guidelines, that people really lives are being saved, and that's great. But there is a definite coding aspect to it, and a lot of the shift is between PQIs and sepsis.
I don't disagree in the sense of, and we struggle with it every day across multiple hospitals, but across multiple physicians, of the variation in utilization of the diagnosis. But I think that, as real as it is, we need to deal with that from a coding perspective and an audit perspective, and not put, clinically, I'm concerned about putting patients at risk of identifying them as potentially avoidable. Therefore, we may not be as aggressive in early identification and treatment. And so I think that there's, a patient concern related to considering it potentially avoidable, when in fact we know, and I could bring multiple circumstances where a patient never sought medical treatment until they come into the emergency department. And there is a difference between sepsis and septic shock. So it's just I would ask that we consider addressing your concern, but in looking at it from a coding opportunity.
But if the patient hasn't addressed it, it doesn't mean that it's not avoidable. I mean, if it were addressed earlier in the community, all of the conditions, when people arrive with acute asthma attack, it is really has to be admitted right then, because the person's in bad shape. But there is something that can be done to potentially avoid that.
But that's a chronic illness that can be managed to avoid the acute exacerbation. This is not that scenario. I can give you a scenario, a real life scenario within the last 4 weeks of an elderly woman had a small lac on her head, didn't seek treatment. Her son-in-law was a geriatrician, came into the emergency department a week later, severe sepsis. This disease can progress very quickly, and it's the body's response. So that's my concern of, when you compare it to the asthma case, they are different clinically in the sense of our ability to understand and better manage the asthma. Sepsis is not that scenario.
Just want to say, also, there's a ton of email traffic among hospitals across the country on this issue of sepsis as they try to comply with that new core measure. There's a lot of definitional issues, documentation issues, so it may be influencing some of what you see.
Pardon me, can I just make one other comment? I think this also points out the importance of looking at the distribution of patients, insured versus not insured, resources in the community versus not, proximity versus not, just in terms of how patients seek intervention at an earlier point in the community versus ending up in the ED. So I think this example illustrates that a lot of different dimensions that we need to pay attention to. And I do agree that overall we have to get our arms around it, but I think it's complicated in a multifactorial way.
But just a general comment. I mean, there's a lot of tension, maybe is too severe a word, but this general hesitancy on the part of the providers to try to take, or to be forced to take a responsibility of things that aren't within the four walls of the hospital, and I understand that. But it is, as I said at the commission meeting, a population-based system now, and increasingly so in phase 2. And so I think Care First definitely supports this idea of expanding the PAU definition. There are obviously technical issues that need to be worked out, but in general, if there are incentives that are very clear and direct and strong, the hospitals will be more receptive to reaching out to their community providers. And so it's kind of a long-winded way of saying we support this approach to expand the PAU definition, taking into consideration some of the technical issues, certainly, but sepsis is something that should be added to the mix. And we would probably expect that there are many other utilization categories that could be added and would support other methods of increasing the incentives for the hospitals to be focusing on these things.
Quick, very technical question. The influence of CMI on the ECMED.
Right.
So if you're, is that impacting this percentage change in that if you're taking the lower level cases and you're avoiding them and kind of what's left are higher intensity cases, does that drive up the ECMED because it's the case mix adjusted admission?
It would. I can put the case count too.
Yeah, the details underneath of this would be helpful from that standpoint.
Just one more quick comment to respond to Bob. I certainly think we're all moving in the direction of the hospital understanding that it's well beyond the four walls. It just takes a while to get that infrastructure to be thorough enough to motivate and catch all of this variation. So just like these indicators are not necessarily now, the infrastructure isn't necessarily now. It takes some time to pull all of that together.
So the last two were, so this is a different way of looking at it. This is the percent of PA if you include all of them. As a state total, 6.5% is coming from Hopkins, another 5% is coming from university, big hospitals, you know, impacting this percent. But at the same time, we need to kind of pay attention to this picture in addition to the hospital percent, right? So you may have a smaller percent if you're a big hospital, but it may be still significant dollars that could create an opportunity under the global budget. And then lastly, this is by hospital, the improvements in PAUs. So you see on the top, hospitals that are reducing their PAUs, and then the bottom is the ones that have increased on the ECMED matrix. Any other discussion on the PAU? Yes, Ed.
Getting to the whichever graph it was, what's the goal on so like sepsis? What's as a percentage? What's a I mean obvious? Well, maybe not obviously, but my guess is that you can never reduce that to zero. Just statistically, it's probably not possible. But what is kind of the goal percentage reduction to get to? Or is there? I'm just because I look at our numbers and I know we're a big hospital, $2.2 billion. So even 1% is $20 million. However, 1% is pretty low when you look at the percentage. Same with university. So I'm just wondering, is there a percentage? Is 1 point? I think we're 1.6% on sepsis. Is it possible to go lower than that? I'm just raising the issue. I don't know the answer. I don't know if there is an answer.
So I'm sure you have nursing home admissions, although your data doesn't show that you are admitting nursing home patients. I'm sure there are improvements. We don't know what it is, but I'm sure, and the literature is supporting, let's say 50% of those admissions could be avoidable. So you're right. We don't really know where that target is, and on the readmission, we are struggling with it. On the PAU, what we are trying to do is link it back to the global budget. And as you know, on the demographic, as complicated as it is, you are still keeping those monies in your base. So what we are doing is moderating the inflation on those revenues and incentivizing. You know, we had these discussions at the beginning. You have global budget. Why are you worrying about all these measurements? They're at risk. They'll figure out and they'll do so. And we know in the past that that's not really working. So we need to find some way of getting unified, clear incentives and messages out to the field to focus the interventions. So I don't know. If you want, I can on my spare time look at your data and give you what that percent from my
I
perspective.
didn't know if there's anything in the literature that suggests that there's certain levels that are
I think that's a fair question.
Unavoidable.
Yeah,
talked about,
and there's some unavoidable in all of the categories. There's some unavoidable readmissions.
Right.
I mean, there, right. So some of it is not.
we do better when we're working towards kind of
I think that's a very good question. I think from the clinical perspective.
I just don't know if there's anything in the literature that suggests.
One of the things, when I was looking at I was in the Health Academy Health Conference and looking at research from around the globe. The sepsis DRG in Canada is number 9, and so that's quite a distance from where it is here. And this variation across hospitals, I'm pretty sure it's not all caused by nursing home admissions. There's some other stuff going on here too, but and we do need to get rid of some of the coding variation. So we definitely shining a spotlight on it might help that, and et cetera. But I also was noticing that, here one of the hospitals that I'm always looking to see what they're doing is the Western Maryland Health System, and when I was looking at their data at one point, I was seeing that it wasn't their number 1 DRG anymore. So I don't know where they are on this list and if they've gone backwards or anything, but so I don't know. I'm not holding them out as an example, because I also don't think that Hopkins and University have very many nursing home patients, so I don't expect them to have very much on the sepsis at all, because they really don't get a lot of admissions from nursing homes, I don't think. So I think it's something to be developed, but and someone might say, well, why does somebody who has more nursing home patients have to address this more than somebody else? Well, it's because that's where the avoidable utilization is. So we have to put the attention where it is, and if there's a lot of avoidable utilization from nursing homes, we have to avoid it. And so if you have more nursing home patients, you have to pay more attention. It's just like MHACs. The surgical hospitals have been much more hit with the MHAC program because they do more surgery. And now the medical hospitals are going to be hit more with some of the PAU measures because they have more medical cases. And it's kind of, to me, it's kind of fair play to, if you have more medical cases, you're going to have more avoidable utilization. If you have more surgery cases, you're going to have more MHACs. And we just have to say, hey, this is actually a little bit of a balancing act that we didn't have before, by putting a little bit more emphasis on medical cases. So, but I hear you on the sepsis issue, and we need to think about it. So we need to.
And again, this is Pat again. I agree. If we know the source and if we have an opportunity to improve, I'm not shying away from that opportunity. I just don't want to put other patients at jeopardy that may be out of that targeted group.
The other thing on the benchmarks, it's not at the hospital level, but at the state level, ARC publishes the PQI risk adjusted by age, gender, and we do see a lot of the PQIs we are much higher than the national. So we could also look for some other benchmarks, kind of see how high it is, what does that low rate look like, given what our location and socioeconomic factors are.
So the CDC, NHS, and infection measures does take into account, for instance, like the multi-drug resistant organism infections, the MDROs. If it's a community source, it's used for the denominator as an adjustment. So that's to the points that are being made here.
Yeah.
And I have to step out.
So this is going to impact the demographic adjustment, and I'm going to go through the shared savings in a bit. So we are also thinking about if we need to change the shared savings from readmission to our PAU percent. So and the timelines for the finals are in May. So we have, a month and a half to kind of think about it and how we want to adjust it.
And on sepsis, and it is something that we haven't measured before. It may be an appropriate, if we're going to use it, to ease it in instead of put it in fully or something. I mean, there are other options other than just excluding it altogether. There's options of saying, well, let's not put the whole thing in this year. Let's put in, some percentage this year, and let's try to replace it with nursing home admissions next year. Or there's some options of how to think about it other than just yay or nay.
Yeah, I think we want to start the discussion. I think we just want to, we've been talking about the PAU. We want to expand it, and given sepsis, it kind of attracts our eyes all the time. We want to start that discussion, but also get some actionable data to start thinking about what we want to do.
Makes sense. I think we have a shared goal on this one. I mean, everyone wants to reduce the harm that comes from sepsis. And I think if I were to summarize what I heard is that I think it sounded to me like your focus was on sepsis coming from nursing home. And I think our concern was making sure that there's no disincentive to identify that pre-sepsis and get started treating it to reduce mortality. So it's probably going to shake out in the coding and the identification.
We have a coding problem, though, because there's some overcoding of sepsis going on here based on the data that I'm looking at. I think it's some of the number of cases is inconceivable.
And the definition problem does contribute to that dilemma.
I would say it's inconceivable, and it's a problem when we start getting into cost rankings and avoidable utilization rankings and all kinds of rankings. So,
and we know too, it isn't just those differences in coding are not just a Maryland thing. It's around the country.
Right.
That discussion is going on.
I actually have to step out, so thank you for working on this.
Agreeing to work on this.
One thing we can do is, since we do audit hospitals each year, we can look at this issue of sepsis in the clinical chart and the documentation as well.
You have.
Well, just
a
couple of quick comments. I was going to suggest looking at internationally for comparative data. I mean, part of the reason, or a big reason, why we have problems on quality is because we have such a fragmented system. But if you look at Canada, arguably have a much more of a population-based system, and they've been under global budgets for decades, and there's more emphasis on primary care and better coverage. So I think that's a good place to look. I just had a question about PAUs, whether there had been any consideration of looking at other types of things to add to it. I mean, one of the, Donna mentioned, and I think everybody knows, that PAUs are very medical centric, and so as a result, hospitals that have heavy loads of medical cases are sort of under the spotlight, as opposed to hospitals that have more surgical orientation. You have the MHACs, but I'm not sure there is a balance. And so I'm wondering, is it worthwhile to look at adding in other categories of more procedures or into the PAUs? And we'd be happy to make some recommendations along those lines.
I mentioned the two that CMS is developing: 7-day post colonoscopy and outpatient surgery, ED encounters.
And we've been looking at choosing wisely list. I think that kind of comes, and I heard in multiple places. Mm-hmm. So far, the estimates are like by the time you take into account all the specific exclusions for choosing wisely and try to measure it from the claims as opposed to the EHRs, the estimates I've seen in the studies were low in terms of the cost saving. So, in terms of opportunity, where do we need to pay our attention and try to improve the care? It seemed to us that the more money was in the medical cases. But
yeah, I'd like to see that.
Yeah,
I mean,
I'll send the references.
Useful.
There's been multiple presentations that Academy held last year or a year before from Harvard researchers, and none of them recommended operationalizing, choosing wisely for that purpose, but for care management purpose.
Yeah, well, I'd just like to match that up with other types of things that we've looked
at.
Right,
Dartmouth has been working on it, so yeah.
Yeah, okay, thank you.
FYI, in Maryland, we also use NHSN for hip, knee, and CABG procedures beyond just the colon and abdominal hysterectomy that CMS uses. So there are other surgical cases.
All right, so we have, I want to make sure, I forgot my watch today, so I want to make sure I'm on time.
It's already 1:30.
So the readmission one, so hopefully some of these information you'll remember from the previous discussions, and I'm going to focus more on the recommendations because I think that's the place where we haven't get a chance to discuss. So on the readmission reduction improvement program background, this is a new program, so this is going to be our third year. And as you remember, first year we had 0.5% rewards if hospitals met the target regardless of their performance. And last year we made changes to it. We created a continuous scale. So the impact of the rewards were in relation to their improvement rate. And also we instituted penalties since we didn't have that much improvement in the first year. With that, so this is comparing Maryland Medicare to the national Medicare readmission rates. So calendar 2013 is base, and our goal is to reach or go below the national by 2018. And Maryland has been declining faster. Some may also argue this could be the regression to the mean, that your expected rate of change would be faster if you are higher than the average. But we also know that we've been paying more attention to readmissions with the ARR program before GBRs and with the new programs after the model. So we've been closing the gap, and so now our gap is reduced from almost 8% to almost 4%. So we cut the gap in half in 2 years. Monthly trends is favorable for this year, so for actually past year, calendar year 2015, that we are on the way to meet our annual target vis-a-vis our all-payer agreement. And this was what we've been seeing before. What you have is 14, 15 historical information, how we did the modeling, and then the bottom is the 16 modeling. The important factor here is the bolded figures, the percent assumption on the percent change in national Medicare. So we have to meet every year that reduction, and on top close the gap by 1/5 to reach the goal. And when we started, the trends were faster, so we assumed 5% reduction. The actual rate of change came actually at a positive of 0.7%. And in 2015, we reduced our assumption to 1.3%, and now we are, the data is showing about half of that on the actual data. So with that, now we model 3 options, if you remember. One is the current rate of change, another one is kind of a regression model to smooth that out, and the last one is the long-term historical trend. And when we add so then we calculate the Medicare, and then from there we compare it to the all-payer target. So our calendar year 2015 was 9.3. With the modeling and with the declining rate of change for national, the models are producing between 9% to 12.7% targets for an all-payer basis. You can always ask me to go back if you have questions, so I'm going to whiz through these. So this is the hospital level performance. In general, 1/3 of our hospitals are meeting the 9.3% target, and then we have a few hospitals that actually have increasing their readmission rate. So for the recommendation, the staff had 2 tasks. Following the last year's recommendation, Commission approved to look at several factors in looking at the readmission reductions. if you remember last year's discussion, we were concerned with multiple factors that may impact the readmission reduction. And the first question was, do we do all payer versus Medicare? And looking at the trend, staff is recommending to keep it on an all-payer basis because the relationship is much tighter this year. And I think last year we saw an ACA impact on the trends. The second consideration was if the hospital is doing a good job in reducing their overall admissions, does that impact their readmission reduction in the opposite direction because of, since we are using a ratio. So the denominator is getting smaller, so your rate may be going up. And this is, Steve Jenks has quite a number of papers on that topic. Because the way we do the risk adjustment, we didn't think that it was a big impact. And looking at the data, we actually see the opposite. If the hospital is reducing their overall admissions, they are also more likely to reduce their readmission. So there is no trade-off that we could see in the data. The third consideration from the last year was the impact of socioeconomic and demographic factors. As you know, we've been working to create a measure to look at this, and we've been looking at area deprivation index, which combines poverty, income, and other factors at the census block level, smaller than a zip code. And preliminary analysis is showing us there is an impact. So people coming from most deprived areas have high readmission rates. The question is how that impacts hospital level performance. So we are working on models to control for that factor. But when you look at the change, right, when you look at our actual hospital level, you'll see that the hospitals that are serving most deprived areas have higher readmission rates, but they also have better improvement in the last 2 years. So we think that if you are looking at an improvement, socioeconomic factors are not an indicator, at least negatively impacting. You know, it could be a positive association, and I think everybody is good with that positive association. And the other one that we were looking at, the observation, trend in the observation, whether if the observation cases are used more, is that impacting the inpatient readmission rates. So when we look at the inpatient readmission rates, we are comparing with, if you include all the observation cases, do the trends differ? And at the state level, there is not much of an issue, but at the hospital level, we do see some hospitals that on an inpatient basis, they are doing a great job reducing their readmission. But once you include the observation cases, the improvement is not that high. So we think we need to kind of deal with it on a hospital level basis because of the variation at the hospital level. In some cases, actually, their improvement is even better when you add the observation cases. The last topic that is staff took attempts to address is the issue of the relationship between readmission rate and improvement. So this is the question of if the hospital has low readmission rate, would they have less opportunity to improve? And before going that, what is the low readmission rate? And you know, you ask about the PAU. If I can get this one answered quickly, I can sleep at night. So, you know, when we think about the risk adjustment, you know, socioclinic, we know it impacts the readmission, but the policy question is how do we address that, right? If we put it as a risk adjustment, basically then we are leveling out the readmission rates and implicitly saying that it is okay to have a high readmission rate for low socioeconomic status in the performance. So at the same time, from the hospital perspective, they shouldn't be penalized for taking care of poorer segments of the population. So we need to think about how we would use that in the adjustment. The MedPAC suggested to create 2 stratified ways of measuring it. Some people are arguing to do combined. And another option is to give additional resources to those hospitals based on the ABI to help with the readmission reduction. If we are ranking the readmission rates, then we need to think about the out-of-state readmissions. when you look at the data, you will immediately see that the hospitals in the border have lower readmission rates no matter what adjustment you use. And thirdly, if we are ranking, our state readmission rate is high, but so is the state average is an appropriate benchmark, or do we need the national benchmarks to judge whether you have a low readmission rate or not from the hospital perspective? And finally, let's see, we figured those all out. What do we do with attainment versus improvement? How do we combine? And do we take the MHAC type of methodology score and kind of, scores are nice, but it is taking away from the actual rate by the time you score. You know, 10 score is different than a readmission rate of 12% or 15%. So how do we get that transparency maintained when we combine attainment and improvement? So we think there is more work to be done if you are trying to get an attainment model for readmissions. And these graphs kind of made us to think what we can do to modify the existing improvement program and address the issue of if you have a low readmission, you have a low opportunity to improve. So what you have in the slide 28 is the base year readmission rates in both charts, so calendar year 2013, and the Y is the percent change year to date. So what you see is, in general, the lines indicate a negative slope. Basically, there is an inverse relationship. If you have a high readmission rate, you have a negative, you have a better improvement, right? And the comment from the commission was to take out the outliers and see what the impact is, and the relationship is still there, but a little bit smaller than the overall state target. So we've been looking at this and thinking about ways of addressing this issue. I think the question is there an issue or not? So we would like to get your input on whether, when you look at this, you agree that there is an issue. You can point out that in the red dots, which are the hospitals, on the same level of calendar year 2013 readmission rate, so if you look at vertically, there is a big variation in terms of improvement. So hospitals who have the same 11% readmission rate, some have declined, some have improvement. So it is not absolutely clear to us that how the variation is not really explained by the level of readmission exactly. Nonetheless, staff took a stab in putting a recommendation out to think about this, and what we proposed is, I'm going to get to this later. What we are proposing is to adjust the target. So if we approve that relationship, what we would do mathematically is to just adjust the minimum target based on your readmission rate. If you do it on a continuously basis, I'm sorry, I'm going to go back to this chart. So if we use this line, we could use this line to change the improvement target. So you could have the 1% reduction at the beginning of this line and continuously increase that up to whatever that percent to the end of the line. So then your range could be between 1% improvement to 15% improvement based on where you are in the readmission. So that's kind of the overall line that you could take. Given the impact of the socioeconomic factors, we said, okay, we are not going to go all the way down. So we'll say everyone who is above the state average is going to be subject to the state 9.3 target. So we are going to give what they call break for hospitals who are above the state average. But for hospitals who are better than the average, we are going to use this line and adjust their target downward. So if you have a low readmission rate, then your improvement goal would be less than the state average of 9.3. So that was the staff proposal in the draft recommendation for dealing with this issue. Any questions on the way that, okay. Good. So then the timing and the attainment issue and the shared savings, this is kind of impacting the timing question. If we are doing these adjustments and not doing an attainment type of methodology for readmission, then the question is, what do we do for the shared savings? So relating to our potentially avoidable discussion a little bit, is this the time to think about broadening the shared savings measure and include other PAUs rather than just using risk-adjusted readmission rates in the shared savings? So staff didn't feel comfortable moving ahead with the improvement draft before we discuss more how we are dealing with the shared savings and to link those two together conceptually. And the shared savings, as you know, it's based on readmission rates, but it's cuts to all the hospitals. There are no rewards, so we are adjusting slightly the cuts based on the readmission rate. So if you change it to a % PAU and find some adjustments, could we substitute the readmission measure from shared savings and put the PAUs in there? And that way, then, we could lower some of the impact on the readmission improvement program. So we want to balance what we are putting on the shared savings with the readmission reduction program because they are relying on the similar measures. And in terms of the timing, as you know, we are into the performance period for the readmission reduction program. So what you have here is we are talking about fiscal year 18 adjustments. So these are for next July, not this July, the discussions we are having. But the shared savings adjustments are coming in this July and looking at a previous period of calendar year 2015. So in the shared savings, we are doing a prospective cut based on a historical period versus in the readmission, it is giving the incentive ahead of the performance period, albeit we are a little late in the policy. So this is kind of moving forward what we want to do. Going back, looking at the calendar year 2015 performance, the Commission's recommendation was, do you need to adjust the penalties looking at the historical data? Here, staff is proposing 3 options. One is recognizing the Medicare improvement rates, given that we improved much better this year on the Medicare. Or we do a similar adjustment that we are proposing prospectively, go back and do the same adjustment for the previous time period and adjust the improvement rates and recalculate the penalties and rewards. And MHA is working on a different way, and I'm going to have Tracy to present that option. So we put them as options, and we would like you to give us input and help us to move towards the final recommendations for the Commission meeting. And with that, the final recommendation for 18 for the future period is continue to set it on an all-payer basis and set the target at 9.5%, and that adjusts the readmission improvement targets downward for hospitals that are below the state average.
Could I just ask a question about timing again? Because you said, you know, get input for the final recommendation, but then you also talked about potentially linking it to shared savings.
Right.
So is that open for discussion, the timing? Okay.
Yeah. I feel everything is open to discussion at this point.
Let's hope not everything is open because we'll be here too long, but yes.
Yeah. So maybe we'll have Tracy to present her slides and then we can discuss them all together.
Could I just make some comments from CareFirst's perspective on the recommendation? I'll try to be brief because we made some of these comments at the Commission meeting. We still think that the focus should be on Medicare for a variety of reasons. One, in particular, you look at the situation, you said that there's correlation between all-payer and Medicare. There obviously would be because Medicare is such a large proportion of the all-payer. We haven't seen consistent performance from year to year. You saw a complete flip-flop in performance from the 14 period to the 15 period, and that's what created arguably a problem where the hospitals got penalized because they were penalized on the basis of their all-payer performance when they actually did well on the test that mattered, which was Medicare. It seems ironic that we're setting a all-payer standard that is based on what we want to do with Medicare. And we have data on Medicare. We have a comparison and a target that we have to meet. We don't have good comparison data on all payer. And when you go back, I spent the weekend going back through the recommendation from last year about how you linked the targets from creating the all-payer target relative to Medicare, and it's confusing as at best. It seems like it's a misplaced approach, and having two tests is very difficult to meet, as we know with the Medicare test and the all-payer test for the model itself. So I really think it's important to potentially look at this idea of just focusing on Medicare. I know other payers are going to say, but we want to keep the pressure on, but we have multiple programs that are putting incentives in place for readmissions. You have this shared savings, you have global budgets that provide incentives on an all-payer basis. You're putting more emphasis on PAUs. Those are all-payer as well. It seems like we have enough in the way of programs and incentives to focus on all-payer. And it just would simplify the methodology and remove these potential distortions that we saw when we shifted from 14 performance to 15 performance, which arguably it did penalize the hospitals too much for the fact that they did perform on the tests that mattered. Sorry, I'm getting overly excited about this.
Yeah, you made me excited. Maybe I should take that. Not everything require a lot of discussions. We discussed this last year. We are meeting our Medicare target right now, and if we start discussing a Medicare-specific program, immediately we need to think about other payer. Commercials don't have that issue. Medicaid has that issue, and as you know, then we need to think about what to do with the Medicaid if we are going to the Medicare one.
Well, I'd like to still just try to have some time to discuss this.
Why not the option one then? If it is better on the Medicare improvement, why not just use the Medicare better improvement rather than worrying about creating it two different scales? I mean, isn't that a compromise to do?
Well, that's what we're saying, is focus on Medicare improvement only and not have two different targets for the industry to meet. I mean, we have no logic.
That's not what my option is. You have 9.3.93 all-payer target. I agree with you. Math maybe whatever it is, but it is what it is, right? So what I'm seeing is then look at hospital level performance and pick the best of either Medicare or all-payer target, and don't worry about creating two scales or trying to get a Medicare specific target. So that's the option one in terms of dealing with this issue and recognizing that if hospital chooses to do a Medicare specific target and improve better, they should get credit for it on option one.
And we'll be one of the payers that will be opposed to a Medicare-specific target. I mean, as you know, we've mentioned in multiple work groups that we would like to even see the contract with CMMI include Medicaid targets in the contract itself. So again, any programs that start to exclude Medicaid in the discussion and in the programs, one, we're going to, and I've mentioned it before, we will consider implementing our own targets similar to other states. Pennsylvania has a program, New York has a program, and they're much more extreme than what Shulé is laying out here. So our position is once you start excluding Medicaid, we'll be developing and looking at our own quality improvement activities.
Just one other point about the base year readmissions. We agree that that needs to be looked at, but the staff recommendation, you took a first crack at it, but it is admittedly arbitrary what you came out with. And I know there's some degree of arbitrariness in all the recommendations there needs to be, but we would suggest, and certainly want to listen to the MHA's proposal, we suggest looking at other options that may be more systematic and also simpler and easier to understand than a lot of the recommendations that have been embodied in the readmission incentive program, reduction incentive program.
Yeah, I'd be open to other alternatives.
I just think that's one of the big problems.
I think we should focus on that one and try to come up with something meaningful.
And if you link it to the shared savings, I agree that there probably is a need to do that because we have multiple recommendations and multiple policies addressing similar things, and the more that they can be linked, I would imagine the hospitals feel this way as well, the better, just for coherency and understanding what the incentives are. So if we had more time to address the RRIP with regard to hopefully these two issues, I think that would be worthwhile, and we would be happy to try to put forward maybe a more systematic and simpler approach.
Okay, this is another approach. I think it's kind of a similar idea, but slightly different.
So I'm sorry, I don't have a slide for this one in particular, but then I'll talk about this. So we've got two recommendations here. One is for the calendar 15 or FY17 penalty mitigation. And that's, I think, what we're talking about when we look at the three different options that Shule mentioned, putting on the table, adjusting the targets for improvement, looking at the better of Medicare or all-payer. And then this third option, we're saying that for calendar 15 measurement that has already finished, that policy had already been approved, rather than really change how that policy works, just reduce the target. So the target was a 9.3%, and we did have a lot of questions this time last year when trying to figure out where to set that target. And what's happened is that we've done really well on the Medicare test, the Medicare unadjusted test that's part of the demonstration test. So we overshot our target a bit. So if we back off to where our improvement is right now statewide, which is around 7.2%, and just change that target from 9.3 to 7.2 and adjust to the scaling, that reduces the penalties on hospitals. Because to us, at the core of this is that we're doing well on our demonstration target, but looking at the data through September, the net penalties are about 28 million statewide. So that seems out of step. So that's the piece that we're trying to fix with these recommendations. The other piece that we would add on to that of adjusting that target is to look at hospitals that were in the had the lowest readmission rates in the base year and then in the calendar 15 performance year. And if a hospital was in that lowest third of readmission rates in both calendar 13 and calendar 15, then that hospital would be held harmless from the penalties. So those two pieces combined are what we're proposing for calendar 15 or FY17 penalty mitigation. And then the slides are about FY18 and how we would do attainment and improvement.
Excuse me, Tracy, do you have anything that just sort of describes that, that's written?
I didn't bring it with me, but I could certainly do that.
Yeah, if you could distribute that, that would be helpful.
So can we stop on that one first and have a discussion about what we want to do for the past period and then think about it? Because I think, you know, there are important concepts there that we need to flesh out. One is adjusting the target based on the performance. You know, my response is, what if we were on the opposite end next year, that we undershot our target and we are not meeting? Would you be agreeing to increasing and putting the penalties? You know, that's not going to work. You know, so it is hard for us to go back and change the target and also being true to our principle of all the things benchmarks should be set prior to the performance period. The other one is, I think, a more difficult thing to think about. So you're proposing to zero out all the penalties if the hospital is at the 1/3 of the best performing in both years. About 10 hospitals, you would say, or less than 10?
No, it's less than 10. I don't have that number.
7. They are not 3. They are, right, I can count, right. They are not 3, but 6, let's say 6, 7, right, around that time. So the discussion with the commission we are having, even in our proposal, is, do we expect all hospitals to improve? I think that's the discussion we need to think about, given that we cannot reliably judge their level of readmission, given that the state has high readmission rate. Should we expect everyone to improve? And I think that gets into the main difference between staff proposal and MHA proposal. And I'd like to open that discussion to everyone on those two questions. No? All right. You want to think, Chad?
Well, I guess I have a question about the MHA proposal. If we were to reduce the target and essentially reduce the potential penalties that the hospitals were subject to. How would the hospitals, is there a thought about what the hospitals would do with those potential savings in continuing to drive forward reductions in readmissions, what they would do with those dollars?
Good question. I would say that hospitals have not budgeted that penalty, and so they wouldn't particularly budget that savings. So their budget for the interventions are already set. Maybe Ed or one of the can help me there. I think I'm on the right track.
First of all, I wasn't quick enough on the green to respond when you said, are there any comments? First of all, I agree with Tracy totally, and I don't know if the other hospitals would agree, but just as we don't budget for the penalty, we don't budget for the reward, and I think right now, I'm speaking only for my own system, which is LifeBridge, everything is full speed ahead, population health, PAU, PQI, readmissions. Every dollar that is saved is put back in that track. And there is one hospital in that group of, I think, in that group of 6 that is from LifeBridge. And we have seen a need to do some leveling. And I think that's where Tracy and MHA are coming from. The playing field has not been level. The hospitals that started their very aggressive work on readmission reduction years ago, it feels like they can never catch up now. And I think I can't recall all 6 or 7 hospitals and what their track has been, but absolutely the effort is not to relax, but to still continue. It's just that, like anything, it's harder. The more you have already done, the harder it is to continue at the same rate. So that's why I would support the MHA recommendation, because I think it's been a glaring need to work on this leveling, actually, for the last 2 years.
I'd just like to maybe have something written so that I could review it and take a look at it more specifically before responding. But if you could provide, documentation of what the actual proposal is, then I think we'd be in a better position to respond.
Right. Yeah, I mean, I'd like to look at it more closely. I think overall, I'm just having a hard time with adjusting a target retroactively. I mean, in terms of any type of quality improvement program, should be, we should be setting targets and not just kind of readjusting it on the after the fact. So I think it's really that's a principle in terms of how we look at quality programs going forward now and today, and I have trouble with the concept.
I know you both mentioned the target and readjusting that, and what would we do if we did not hit the Medicare target? What would we want to do then? And I just want to say that if we were to not hit the annual demonstration target, the Medicare unadjusted, then the contract calls for the explanation period to evaluate why, and then if that evaluation of why we didn't meet that target was not satisfactory, then there's a corrective action plan. And so I think we're all aware that if there were a corrective action plan, that would involve an aggressive target and a more aggressive policy, albeit in the subsequent year. But I think it's I don't want us to leave with the idea that, let's say we didn't hit the Medicare target, and we would just hospitals would just go on our way. That we know there would be something more aggressive.
I mean, I think what Tricia is saying, on principle, if we set the target, there are questions about it, but we want it to be aggressive so that we can ensure we meet the Medicare target, right? So we are at that point now, and if we go back and reduce it, then you will never believe my aggressive target this year. You're always going to bank on saying, oh, well, come next year, we'll perform well and, we'll be fine. So I think that's a dangerous precedent to put forward. And if you think that we should do something different, then I would say, okay, why not just then use, you're using average reduction. You know, we've been doing the relative ranking quite a while now. Then we could say, okay, we are going to, you know, penalize hospitals who are below the average. You know what I mean? Like, it doesn't make sense to me that going back and using a state average and retrospectively adjusting, I think this is going to be very dangerous precedent to put.
Good question on, I guess, what you had raised on the hospitals that aren't meeting the all-payer but are meeting the Medicare.
Right.
So could you expand that a little bit?
So that, to me, is kind of, that was a way of addressing two comments, maybe, you know, care first concern on focusing on Medicare, right, and also giving credit that since we did good on Medicare, you know, hospital may have done good on their Medicare improvement, but on all-payer basis, if they are getting a lot of penalties, could we substitute it to give credit to both comments without really changing the benchmarks?
So you would stick at the 9.3.
Right.
And if a hospital didn't meet 9.3 on the all-payer but made it on the Medicare,
right,
then okay.
And it's not 9.3 on Medicare. It's the.
I'm not changing the target.
No, I know,
yeah,
but
right,
you have a 9.3 on all-payer.
Right.
I think that's part of the confusion. If you go back to your methodology from a year ago, there is a very sort of.
Right, but I'm not. Yeah, I'm not suggesting to go back and use the Medicare target. I'm sticking with 9.3. Right.
Okay,
because that's what I thought. Then I think I'm still keeping my all-payer emphasis on the target, but giving credit for a better Medicare performance. So I'm not going to use it.
To get relief under this policy, they'd have to improve a 9.3 on Medicare.
On the Medicare, yes. Yes. Yes.
And we haven't modeled what that looks like. My guess is that doesn't do a whole lot to the $28 million in total net penalties.
Yeah, I need to see what that.
Under both,
okay,
it's 6 hospitals.
Yeah.
It's just 6 different. Well, there's
well,
actually
well,
2.
I think just to be clear, for the MHA proposal, by resetting the target, that helps all hospitals.
Okay. Right, and I don't know when the distribution of the.
Right, it will be different. Right, it's not a lot of hospitals who would benefit from either policy.
The distribution of the dollars.
Right.
You're right. You're right.
Yeah, I mean, I just would tend to agree with you. The idea of going back and changing a recommendation is problematic because then people don't believe what you put out first. They think they can always come back in and ask for forgiveness. I mean, the payers could come in the following year and say, well, we really did poorly last year, so we want to add penalties, but we get laughed out of the room. And so it is better to keep to your word. On the other hand, there's this issue of fairness and also confusion, and that's why we recommended looking at Medicare, only because I think that's what caused the problem last year. It's because you had 2 tests. And so, I mean, we'll agree to disagree on that one. And I think it creates the complexity that you know, led to this issue where the hospitals got slammed because they didn't meet the all-payer standard, which was an completely arbitrary standard. We don't know if 9.3 is the right number. We don't have data nationally to compare ourselves to that. And that they did well on Medicare. So as a result, there's some degree of unfairness. And I think it's because we're using 2 targets.
We are not, just clarification, in the program last year we had 6.7%. It was an all-payer target. What we didn't do last year was we didn't add anything on top for the all-payer. We just said Medicare is 6.7, all-payer is 6.7. And last year we looked at it because of ACA. I think the all-payer trend and the Medicare diverged, so we added additional one on top of the Medicare, but we still have one all-payer target in both years. What you're saying is forget about the all-payer target and just use the Medicare number.
For the purposes of this recommendation, we can augment other aspects of the system.
Okay. I mean, it's your proposal. I would defer to the commission. I think from staff perspective, the other, when I said everything is open to discussion, commission is concerned with all the changes we're making to program every year, and staff is trying to prioritize the issues. And with the MHAC, it didn't work that well. With readmission, we are also getting dragged down to topics that we discussed last year made a decision. So I would just keep that in mind. All right, maybe we are ready for the attainment versus improvement for the next year.
And thank you for the opportunity to talk about our 17 and our 18 proposal. So in here, what I have are what we are trying to accomplish with these recommendations, what our policy objectives are. I'll talk a little bit about the measurement concept, which is how would we put together, what structures do we put together to be able to do attainment and improvement. I'll talk just a little bit about MHA's predictive model, because to do an attainment, you have to be able to predict a readmission rate by hospital. We don't have results in here today, but I'll also talk about next steps. So policy objectives. One, we wanted to develop a robust model to predict hospital readmission rates to be able to do attainment and improvement. And in building our risk model, we built on known predictors of individual hospital risk, including clinical comorbidities and the presence of a significant mental health or substance use condition, age, gender, and other factors. We also made an attempt to include socio-demographic proxy variables. The one thing that I want to emphasize about our policy is that in developing this risk model, we thought it was important to be able to account for how risks work in conjunction with one another. So not just one risk at a time, not just one factor, but multiple factors and what their interactions are. And really we're looking to overall just try to develop a more fair policy. Service lines that we've talked about a little bit earlier, that could be layered on top of this. We don't include any of that here, but that could be layered on top. And there may be other changes that we may also want to look at. So, for example, cancer cases and what kind of impact are they having? And it's we want to look a little further to be sure that all exclusions are, all planned readmissions are excluded as intended. So in our measurement concept, we continue to use all-payer, unplanned 30-day readmissions. We do a scoring based on an observed to expected performance. And the model that we use is a multivariate regression model, and that's to determine this expected readmissions rate. And from that expected readmissions rate, that observed to expected ratio, when just like in the HSCRC model where we have an observed to expected based on the DRG SOI statewide readmission rates or norms, that gives us an observed to expected multiplied by the statewide average to get the risk-adjusted rate. We would use those risk-adjusted rate in that same way. Other concepts are that there's a threshold and a benchmark, and this is similar to the QBR program, the MHAC program, and other national quality programs. And we would look at the hospital's score, the better of attainment or improvement. So attainment is a hospital score based on that hospital's performance relative to a target readmissions rate. And that score could range from 0 to 10. An improvement score is based on the hospital's improvement year over year. And that score could range from 0 to 10. And then the final score is the higher of attainment or improvement. The threshold and the benchmark. So the threshold is the minimum performance score required to begin to score points. Typically that's set at the average or the median performance. The benchmark score, think of that as the best practice performance. And that can be set top quartile, top decile, or some other metric that would be considered a benchmark. So this is just a little visual example of how you would get an attainment score with the threshold. If that were set at 13.49%, and the benchmark were at 10.87, a hospital with a rate of 12.44 would have an attainment score of 4. So somewhere along there. And then whatever the hospital's final score is, the better of the attainment or improvement would translate into a payment adjustment. We would say that there should be the potential for positive and negative payment adjustments. And again, that's similar to QBR and MHAC. The one difference that I'll point out here is that in both the QBR and MHAC programs, there are lots of these attainment and improvement. You get an attainment and an improvement score for each metric. So for MHAC, all of the 66 PPCs, you get an attainment and an improvement score, and then roll those up. QBR, each of the metrics in there, you get an attainment and improvement score, and those get rolled up. So here on readmissions, it's just one rate that we're looking at. So that does make it a little more challenging. But I think
that's also the question, whether it's worth going through the scoring system if you have just one measure. Is there a way of simplifying it?
Yeah. And there may be,
yeah.
There may be. So that was kind of the measurement structure. This is a little bit about MHA's predictive model. And here I want to emphasize that this is a work in progress. We have done a lot of work on this model, but there are still, it's not set in stone. There's still modifications that could be made. And I think in our best hopes that we could combine the work that we've done with some of the work that HSCRC has done and pick the best of both worlds on that. So I think early on I talked about we used known predictors from a wide literature search and predictors that are well known and that observe to expected value. To develop that, we have to be able to develop the expected value. Our data source was the HSCRC inpatient public use file, or this revisit data. And to develop the model, we used admission dates from July 2012 through September 24. For the model validation, we used the discharges for calendar 2013. The variables that we use for risk adjustment, we used the Charlson Comorbidity Index, and that's a weighted index of 17 conditions. And you will, there's details in the appendix of what those conditions are and how they're weighted. It's a commonly used risk adjustment tool, and this should be thought of as kind of analogous to the DRG SOI norm. So you could swap out one for the other if you thought that one did a better job than the other. We used age, gender, race, ethnicity, the primary payer, the level of poverty, and we put the DRG case weights in there, and a mental health substance use disorder indicator. So just a word about some of these. The data set, this public use data set that we have, it's some of the variables are rolled up to protect patients' health information. So for example, age is in age categories. The level of poverty, we have data at the census, at the zip code level. If you really wanted a better socioeconomic indicator, you'd want to go at a more granular level than that. So I think that's a limitation that we have. Sure. I don't remember. It's a question for our developer, and I don't think he's on today. Thayer, are you on the phone today?
Can I ask a question about race and ethnicity? You actually saw adjustment in the literature for those factors. They make me very uncomfortable. The other ones, not as much, but that line item is not comfortable for me.
Yeah, I think in the literature you could look at it two ways. One is, the research papers trying to predict readmission rate, determinants of readmission rate. Obviously, race and ethnicity becomes an important variable there versus the literature on performance. And I do think that the variables for the performance would be different in the literature than the research articles.
And I think this brings up the very good point that that we talked about earlier, is that we don't want to adjust away these differences, and we don't want to try to explain away disparities. But again, this is work in progress, so we may want to include that so that we can see what those differences are. And this is the variable that we used is coded in the inpatient data set. So it's a relatively new variable. Our history is that something that's relatively new and hasn't been used may not be that great, but the only way to make it better is to use it. So,
Tricia, some of these just seem to overlap to me. So, I mean, primary care, when you look at Medicaid, you're going to get level of poverty. I mean, there's going to be, so it just seems like they're not discrete in themselves.
It's true. There is some overlap. When we do the multivariate regression, the stepwise, we have run multiple iterations of which variables to have in, which to have out, what gives the best prediction, and this was the best collection. But you are right, and in the appendix we have some tables that show odds ratios of the different variables, looking at unadjusted and then adjusted, and then another nice table that shows the predictive value of each variable. But that is true. Some of these do overlap here. And
I'm sorry, and how predictive is the model?
The area under the curve with these was around 70.7.
Which is the same number as when you just do APR, DR, GSOI.
And I think here, this is where we'd really, we would really like to maybe try swapping out some of the, say, primary payer and level of poverty with the area deprivation index, if you're, when that is comfortable, to see how different do those work. We'd also like to see this run on that more granular level.
And you keep referring to an appendix. Well,
did I not include an appendix? I did not include the appendix.
Yeah, okay, okay, sorry. Yeah,
I didn't think we were going to get there.
Yeah, okay, that's right. If that could be provided as well, that would be helpful.
I think we meant to have this as an update to see where we are with the risk adjustment from MHA perspective. Staff is working with Mathematica to do our modeling, but it's not ready yet. So, and then have a discussion about, given where they are, given where we are, do we spend the next, is it reasonable for us to think in the next 2 months we're going to come up with an attainment and improvement model for the May final commission meeting, or what is our strategy to get some kind of compromise or some reason, not a compromise, I apologize, my language is skipping it today, but some reasonable way of adjusting the existing program given the timelines we have.
So this just briefly speaks to the Charleston Comorbidity Index as a predictor of the 30-day readmissions. You can see the difference in readmission rates for people who have 0, 1 to 2, 3 to 4, and 5 or more score on the Charleston Comorbidity Index, and the 30-day hospital readmission rates by CCI score. But again, that's not the full model. That's just the Charleston Comorbidity Index. And our next steps, I think I talked about some of these already. Certainly, we would agree with any time that we're doing an attainment score, we need to include an out-of-state adjustment. What we have right now is Medicare unadjusted data. As I mentioned, we have some limitations with the public use file that we have. The area deprivation index could be an alternative to some of these socio-demographic variables. We could also try the HSCRC norms in place of the Charleston Comorbidity Index. service line analysis could be layered in on top of that, or there could be other refinements as needed as we go. So we're optimistic that this could be something viable in time for a May final decision, but this is where we are at the moment.
Any comments on the timelines? You know, thinking about the questions we have on the variables we want to include, and thinking about how we are going to do scoring, attainment versus improvement, and the benchmarks. We've been, just like the other work we've been doing in terms of comparisons, we are trying to create a national benchmarking data, trying to match the Maryland hospitals with national hospitals with certain characteristics. And if you remember, this was a discussion we had with VHQC back last year, trying to get that from them. But now our contractor is on board, and they are working with us to come up with some benchmarking. Whether we use it or not this year is, I don't know, but at least it will be another information that will be helpful in looking at the readmission rates.
Yeah, I mean, the time frames are short, but I think it's fair to entertain the MHA. You're going to do more work with Mathematica. We'd like to propose something which we think is simpler than either of the methodologies that have been discussed so far. So let's take a shot at it, and you know, we're prepared to circulate our proposal in the next week or two, so hopefully people will have a chance to read it, and then we can discuss it at the next meeting and just take a look at what's there and see if anything leaps out. If not, then default to whatever you think is best and make that recommendation.
Yeah, I think that's Tracy. I'm just trying to understand, because I think, you know, I always have, I like to reward improvement, but I also have I struggle with it in terms of where you set a basic threshold and what you want to achieve in your program. So, for example, if a readmission, you know, if a hospital has, you know, way above the average, but they improve, are you saying that there's no financial targets, you know, taken away from them? So penalties taken away from them. So I think it's, you know, it's a very complex issue that within 2 months I struggle with us coming to agreement on, something that's not just attainment, but it's risk adjusted and it focuses on improvement. Again, I think those are all concepts that I would love to entertain. I just don't think we're going to have in 2 months an agreement and fleshed it all out. So
yeah, so we don't actually have 2 months. So if we are coming up with a final, it's the next April meeting, which is 20th or something, with 1 week of spring break in between. So
less than 2 months.
So I think if we are realistic about what we want to propose in the May meeting, then by next we need to get kind of these models, ideas more developed for the next meeting, work group meeting in April.
Can I just have a question about going back to the first bullet of the one option of improvement in Medicare? And I'm sorry, actually I'm going back to a year, I apologize. But can I ask a question? And then just for clarification, I'm just trying to understand is it actually a better of the two, or is it one or the other met target?
Better of the two, right? Because
regardless, right, regardless if you hit the 9.3.
Right. Substituting all payer number with the Medicare number if it is a better number, better improvement. Not changing anything else. All right, so I think we have a plan. So in timeline, I appreciate all your work. I think this is I don't want to minimize. I think this is a great start, and there is a lot of promises in looking at this risk adjustment. It's just I'm not sure about the timelines, and also if we are going back to strategic discussion, if you are going to change a lot of things come next December, you know, how much energy we spend now to come up with it, only that we change it next year. And again, Commissioner's messages try to be mindful of changing these programs every year significantly. We need a consistency in the programs. All right. Oh, we have one more agenda item, right? But
could you also just remind us when's the next meeting in April?
I don't know.
April 20th.
Okay, so it's after the commission meeting. And so
Right, we are not going to the commission meeting in April, so the final we thought will be in May.
Okay.
So I'm not going to go through because I think I want Andy to talk about the GBR infrastructure reports a little bit because since it's related to the earlier one on the, the clicker is with Stacy, but you could look at it basically right now the recommendation is all the numbers from last year. We didn't make any changes to the percents at risk from last year, thinking that we need to think about how readmission recommendation is going to be formalized. That will inform how much revenue at risk we would want to put on the readmission one and also on the shared savings. And then you have the updated numbers in terms of the total impacts. And then I think the draft includes the fiscal year 16 results for each hospital. Andy, with that, can you talk a little bit?
Sure. So briefly, we mentioned when we presented the GBR infrastructure reports in January that we would be reconvening the sub-work group to update the template so that we could get better data and better analysis of the GBR infrastructure investments in future year reports. So the subgroup has met once. We discussed a number of clarifications to categories of investments as well as some general skeleton discussion on outcomes. We're working with the programmer to update the template, so we really think the template will be much more user-friendly in the upcoming year, and we will have a second meeting with the subgroup. I'm pretty sure it's going to be March 30th. I've placed holds on the subgroup calendar, but I think the final will be March 30th, where we hope to present our updated template. And I just would reiterate Shule and Donna's comments about the outcomes and the focus for kind of looking at process outcomes and long-term population health improvement outcomes as a focus of our template update.
We'll pick up on this topic in the next. Maybe I'll put it in the first agenda item so we make sure we cover, because I think even though it's working under subgroup, there are a lot of questions that we need to address at this level. So think about how we are looking at those reports, what information we want to have. Thank you all for your patience and being here. And I guess any comment on the public side? I don't want to, you guys are dwindling. All right. Thank you.